Okay, hello everyone. Welcome to the September Self-Care Forum on Men's Health um, from Garnet Health. So tonight we're just going to be reviewing a couple topics. We have some great experts here, and just a little bit about what the Self-Care Forum series is. It's a really an expert multi-specialty team, which we certainly do have assembled here, and just talking about physical, emotional, and mental health. And the topic for this month is men's health. And I'll just go through some quick introductions to introduce all the wonderful doctors that we have here on the call. I myself am Dr. Joseph Chavez Carey. I'm a family practice doctor. I practice in Goshen, and I'm also the director for primary care for Garnet Health doctors. And we also have, in my Brady Bunch screen here right below me, I see Dr. Aborby. He's Dr. Samuel Aborby. He's a urologist with Garnet Health doctors, and he also has fellowships in endourology, laparoscopy, and robotics. To my left is Dr. Nkatia. Maybe just wave or say hello when I say your name. This yeah, so you pop up. He's our wonderful cardiologist with board certified here and with Garnet also. And then last but not least, Dr. Greenblatt, Hank Greenblatt, fellow NYU grad, as we were discussing before the call, and dermatologist in Newburgh, right, Dr. Greenblatt? Is that correct? Okay,
that's correct.
So we're just gonna kind of talk about men's health topics, and each of the doctors here will kind of weigh in and give their tips and advice on some topics. So I'll kind of get the ball rolling and throw something out, and then I'll ask the three of them to weigh in. We'll do a couple topics, and then we'll have some time for Q&A at the end. So the first one is, it just talking about screenings. There's a lot of screenings that start happening. It seems like as we get older, it's more and more. And what about the importance of screenings? How about that getting older? The role of genetics and family history. I'm just going to go alphabetical. I'll just go with you, Dr. Aborby. Anything that you wanted to weigh in on that for screenings, family history, genetics, things like that?
Yes, absolutely. This is such an important topic, and not just urology, but all of medicine nowadays. First of all, I want to thank Mrs. Moira Mencher for putting this great, esteemed panel together. It's a pleasure to be here with my fellow panelists, and thank you for hosting Dr. Chavez Carey. So, in urology, when we talk about screening, there's really only one cancer that we screen for, and that's prostate cancer. Just to give you folks some background, some of you may know this, but prostate cancer is one of the most common cancers that men have. You have approximately 1 in 8 lifetime chance of developing prostate cancer, and somewhere between 1 in 30 and 1 in 40 chance of actually dying from prostate cancer. And so many of our attendees have heard of the PSA. And so this is something that revolutionized prostate cancer, because when it was introduced in the 1980s, we actually were able to take the disease from being diagnosed at a very advanced stage and brought it down to being diagnosed at a very early stage where treatment was still possible. And so this had the effect of, well, number one, initially diagnosing many more prostate cancers, but also allowing men who were diagnosed to actually be cured. An unfortunate side effect of this blood test was that it also identified men who had elevated PSAs, which is, as I mentioned, a blood test that did not have prostate cancer. And so many men were subjected to unnecessary prostate biopsies. And some men who, we found out that some men who actually ended up being diagnosed with prostate cancer would have done the same, actually, whether they had treatment or not. So we've kind of realized in urology that we need to find a happy medium. And so nowadays, when I have a patient that comes to see me to discuss prostate cancer screening, there's a few things that I want to ask him. Okay. It's not just, well, what's your PSA? It's what has your PSA been over time? Has it been checked in the past? Because we know that if you start off with a high PSA and it sort of stays flat, you're probably not going to have an aggressive prostate cancer. But if you have a prostate cancer that has sort of a velocity curve like this and you're seeing higher and higher levels, this is concerning. We know that family history is important. And so it used to be, you might have heard 20 years ago, maybe somebody would ask you, do you have a family member with prostate cancer? Well, nowadays, the questions that people ask are, do you have a family history of prostate, breast, pancreas, colorectal, ovarian cancer? Because all of these are actually linked to prostate cancer. And you want to know what age your relatives were diagnosed and how aggressive the disease was. We also know that there can be certain racial predispositions, not just to having prostate cancer, but to having aggressive forms of prostate cancer. So it's no longer, PSA and prostate cancer screening is no longer in a bubble. It's a global picture. And you assemble this picture, and then you ask the patient basically, what are your wishes? If you were to undergo prostate cancer screening and prostate cancer was detected, would you want to be treated? And so once you have the answers to all these questions, you can proceed with doing the PSA, doing a rectal exam. And if there is enough concern, you move on to the diagnosis phase, which I can get into at length, but I'm sure there are other panelists that probably want to jump in with other important information.
Oh yeah, and there will be time for Q&A at the end, because there's a lot. Obviously, in any one of these couple-minute little answers, there's a whole another hour of talking. But let me throw it to you, Dr. Greenblatt. What do you what do you think about when you think about kind of screenings, aging, genetics, family history as far as dermatology?
All of those factors are important in dermatology. A strong family history of melanoma, for example, confers a significantly higher risk for a close blood relative of developing melanoma. Now, melanoma is just one type of skin cancer, and luckily it's the least common of the three major skin cancers. But when we're talking about screening, that's really the one that's most important. Time is of the essence. You want an early diagnosis with melanoma, because the prognosis of melanoma depends on its depth in the skin in fractions of a millimeter. Most of these grow slowly, but clearly you want to find these early. So I'm a big fan of screening. Screening in dermatology is very simple. It's very low tech. A patient comes in, they reveal to me as much skin as they are comfortable revealing, and I just look with my eyes. And based on experience and being very careful to look at all of their moles, I'm screening sometimes scores of moles, sometimes 100 moles or more in a single patient. And I'm looking for things that are atypical to my eye. You know, we all read the different criteria for skin cancer, things that are irregularly shaped, multicolored, large size. But the most important factor for skin cancer is something on the skin that has changed or is changing. So I'm looking for moles that grow, that darken. I'm looking for new growths on the skin, new moles, especially in people over 50. A new mole for a 12 or 14-year-old is normal. A new mole in somebody my age, that catches my attention. So I'm looking for change. And that's, if I can make one point to our viewing and listening public, it would be to watch things on the skin, watch for things that are changing, growing, evolving, have that checked, have a low threshold to have it checked. Most things I look at all day long are totally benign. I can reassure the patient, no procedure needed, no further testing. But I also certainly see skin cancer in my office every day. Without exception, I see new skin cancers every day. And many times it's in patients who are coming to see me for something else unrelated to the skin cancer that we discovered. So I'm certainly convinced and biased in favor of screenings. I think they're low tech, they're inexpensive, they're covered by insurance, and we find things early, we make a big difference. And very often we surprise people with the things we find.
Yeah, thank you. That's really interesting to hear that, someone will come in for something else, and just by taking a look, you're able to identify that. So that's really great.
Yeah.
How about you, Dr. Incatia? Any screening or family history, those kinds of things, genetics for cardiology?
Absolutely. So essentially, as you know, heart disease is the leading cause of death in this country. It's also a leading cause of disability in this country. It's a lot of heart attacks every day. So I think from my standpoint, we only screen most patients for things like blood pressure, high cholesterol. If you're a smoker, things like aneurysm. If you have things like in your family, like things like Marfan syndrome, we screen for big aneurysm in your neck, also in your heart. Then the question is, when do we screen these patients? I think the key is as early as possible. So I would argue that maybe at the age of 18, 20, you should get screened for at least blood pressure to make sure it's not high. Because if you leave it for too long, what's gonna happen to you is gonna have a stroke or heart attack or even a dissection down the line. How about cholesterol? If it's very high, your arteries can get clogged up. And what that can lead to is eventual heart attack or even a stroke. How about things like plaque buildup in your heart? We see all the patients that come to the office with a big list of things to screen for. But the idea here is that if you have a lot of risk factors, like I said, blood pressure, cholesterol, maybe diabetes, and you have plaque in your heart, you're supposed to be screened for that. The other thing is for men, especially if you're a smoker and you're over 65, we screen for things like aneurysm, because if you don't screen for it, what happens is the big artery can actually rupture and cause you to die.
Anyone who's ever been a smoker, I think it's at 65, or I forget the age range.
65 and above, right, for men.
Yeah.
For women, age can be higher, but if you have multiple family members that have had dissection, rupture, then you should probably screen them early.
Yeah. That's a ton. All of what you guys just said is a lot. I'll try to say a little bit about, from a pulmonary perspective. We had expected to have a pulmonologist, Dr. El Zarif, with us, but he had something come up that he couldn't make it. But I'm thinking about smoking again. I mean, that'll be a theme. If you're a smoker, or if you've been smoking for long enough and or quit recently, you might actually consider getting screened for lung cancer with a CAT scan. They do recommend that now, and I've actually caught a couple of lung cancers with that approach. So that is a very effective thing that we have now for screenings. I'll also just give the family medicine perspective. I mean, this is kind of my wheelhouse, right? This is what I do all day long. Screenings are tough because you're taking someone who's coming into you perfectly well and healthy, as kind of as Dr. Greenblatt said, and you're trying to convince them to either undergo some kind of a test or evaluation to see if they have an undiagnosed health. And that can be tricky, and sometimes there are risks associated with screening. You have to think about a procedural risk that might be associated with some kind of screening, but in general, the screenings, I shouldn't say in general, the screenings that your doctors are recommending for you, have been around for a long time. They're tried and true. They're designed to find disease early, diseases that when they're detected early, like skin cancer, like heart disease, that have improved treatment outcomes. So things like colon cancer screening, we talked about prostate cancer screening, Dr. Borby, heart disease, skin cancer screening, all of those. And a lot of that it sounds like a lot, but because we do this all day long, every day, it's kind of second nature to us. When you come in for a visit, we're going to go through all that really quickly, 5-10 minutes, and you'll kind of be covered. And, you can rest assured that you've done everything you can for your health, to update your health.
If I can maybe add,
Yeah, go ahead.
continue one along those lines. I think the concept nowadays that we try to get across to our patients is a concept of shared decision making. So in the past, it was you had a doctor, the doctor said what you needed, or what he thought you needed, and you followed his advice. It wasn't so much of a two-way street. When I see a man, yes, when I see a man in the office, and he's wanting to talk to me about prostate cancer screening, I want to actually take the opportunity to educate him. If it's a man that is significantly overweight, he's had several heart attacks, he may be on oxygen. We want to take into account what is this person's life expectancy, and is there a benefit of screening for prostate cancer at least? Because we know that prostate cancer, for the most part, does not behave as aggressively as, let's say, a melanoma or a brain cancer. And so we have to explain that to the patient that, sure, it might be simple to just do a PSA blood test, but what are we really going to do with those results? If your life expectancy is 5 years and you have a high PSA, what am I going to do with that result? Am I going to subject you to a biopsy? And then in the course of the biopsy, you may get a severe infection and actually end up with significant morbidity or even pass away because we did that biopsy. Are really doing you a favor? So I find that oftentimes when we actually have this discussion with patients, a lot of them opt actually against screening because they don't really see it as a benefit for themselves.
Yeah, absolutely. Anybody else want to add anything?
I think the point here
That's
is
a really
that
good point.
you want to prevent disease down the line. So from my standpoint, if you're diabetic, you have high blood pressure, you have high cholesterol, you're a smoker, I think it's important to get screened earlier than most people. Because if you wait for a long time, what's going to happen is you're going to come home with a big heart attack or even a big stroke. So I think the sooner the better. I mean, sometimes people think we're doing all this testing, but I think from my standpoint, it's all about, do you need this test or not? If you need it, we're going to provide it for you. If you don't need it, then probably not. I'm going to say maybe come back a year, maybe in 2 years for further questioning.
Yep. All right. That was, I mean, yeah, we could obviously go on and on. It's a really great but important topic. I mean, and the truth is that, just a lot of people don't, follow and get these screenings done. And most of them are very simple, like, simple blood test, blood pressure, easy to do, skin check with your dermatologist. So mostly can be accomplished with, an annual physical, that kind of thing. So good. And then I think also just the importance of knowing what your family history is, knowing your own risk. I mean, a lot of times people will come in with me and like, I don't really know what my family, before your physical, especially as you get into your 50s, or while those older relatives are still with us, maybe someone in the family should kind of gather that, if you have siblings or you yourself, just to gather that family history. And as genetics is going to be coming, I mean, if we're having this talk in even a few years, we're probably going to be talking about some kind of personalized genomics that each of us will have. And, now really know what my risk of these different diseases are. So it's only going to become more and more important as we enter that era. All right, I'll move on to the next topic. So that was screening, genetics, family history. All right, so kind of screenings is, things that your doctor can do when you see them, learning about your family history, your genetics, all that stuff. What about the importance of, a good example is like, just healthy lifestyle, exercise, diet, avoiding, we already talked about smoking, but I'm sure we could talk more about that. Um, you know, just thinking about those kinds of things and how they interact with our health. And what I'll do this time is I'll just go in reverse order, if that's okay with you guys. I'll start with Dr. Nicotia. So as far as cardiology, as far as your heart health, what would you have to say about the importance of lifestyle?
I mean, that's very, very important. I think exercise, for instance, I think they recommend at least doing exercise with moderate intensity 4 times a week, right? So that means, you're taking a walk, especially in the summertime, you can take a walk. If it's cold, you can take a walk, like maybe in a mall, to get any activity in your body. Also diet. I mean, I think most of our diet here are full of carbs and sugar, as well as a lot of fat, right? So I think the best thing I do for my patient is, one, we can talk about what diet I think they should be on. If it's challenging, I can have a nutritionist, which we have in our practice. We kind of help them tailor their diet, because each diet is different for each person, right? So, like my BMI is different from your BMI, Dr. Carey. So I think the important is to see a doctor and talk to me about what is the plan going forward, right? So if we need a different diet, then we can have a nutritionist. If I can help you, I can help you. And actually now that there are a lot of important medication that we are giving out now for people who are overweight or obese, that can help reduce their BMI. So I think the key is coming in to see a doctor, your primary care, your cardiologist, and it's a whole team that we can talk to come up with a good plan going forward for you.
Diet and exercise. Yeah, I mean, it's the old sort of saw, but it's absolutely true. Dr. Greenblatt, lifestyle, things that folks can do in a preventative way on their own to help prevent some of these diseases.
Yeah, lifestyle is intertwined in dermatology in so many ways. There are a number of skin disorders that are made worse by a poor diet. Acne, psoriasis, eczema, rosacea, a condition I see in many adults. Skin cancer itself is associated with a higher BMI. Psoriasis gets worse when people are heavier, and a lot of those people have the comorbidity of extra heart disease. So diet, I couldn't stress enough, and that is something I discuss with patients. I think it's very important. Diet and lifestyle also have an impact or can be a problem related to medications that people take. I have medications that can't be mixed with alcohol. I have medications that can't be mixed with dairy products. I have some medications that would cause more side effects or greater toxicities because they would stay around longer mixed with certain foods. So diet is something we discuss routinely. Lifestyle is important to minimize skin cancer, particularly avoiding sunburn. Again, if I make just a couple of points tonight, one of them is look for things that change, look for things that are new, have them checked, and have a low threshold to check new or changing moles. And the second would be don't sunburn. Sunscreen, we could talk about that for half an hour alone. And that's one strategy for preventing sunburn. And I think sunscreen is useful for people who want to use it. I'm not a fanatic about sunscreen, unlike most of my dermatologic colleagues who are. I just tell people don't burn, whether that's the time of day that you're out, the kind of clothing you wear, wearing a hat, standing in the shade. There are lots of simple precautions people can take to avoid sunburn, because sunburn clearly relates to skin cancer. It's clearly the leading risk for skin cancers, other than some rare genetic syndromes. So lifestyle is very important in dermatology. And I think what's generally good for one's health, such as proper rest, proper hydration, proper exercise, good diet, has an impact on, I think, all the diseases all of us are going to talk about tonight. And that definitely includes dermatology as well.
Yeah, it's amazing how it all kind of plays, and that the body just seems to really want to move, and good nutrition and not too much sun. And I would say smoking too, right? For your skin, right? I mean, for those wrinkles and stuff like that. So okay.
Yeah, and stress. You also mentioned stress management when we talk about lifestyle. Huge impact on many dermatologic disorders, and I'm sure on, again, many of the diseases we're going to talk about tonight.
Yeah, you stole what I was going to talk about. but
I'm sorry. I'll let you get into it in detail.
Go ahead, doctor. Go ahead, Dr. Forby. What would you say about lifestyle when it comes to urologic health?
Yeah, so I would say the single most damaging thing that somebody can do in terms of the bad habits is the smoking. And I'm just gonna, as you were talking, I just thought of an example. This could easily be a patient that I see. I'm just gonna run through it. Okay, so a patient comes to see me who's a smoker, and let's say he's having blood in his urine. He's urinating blood. Well, I end up putting a camera in his bladder, and I find that he has bladder cancer. And the bladder cancer is almost surely caused by the smoking. And so, but not only does he have bladder cancer, but we did a CT scan, and he also has cancer of his kidney, the lining of the kidney, which is also associated with smoking. Okay, so he has two cancers, both of the lining of the urinary system, both related to smoking. And so he needs to undergo a major surgery where I have to remove his kidney, part of his entire ureter and part of his bladder, which could be a 5-hour surgery. In order to do that, I have to send him to Dr. Nkatia, and because he's a smoker, he has to get clearance. And in the course of seeing Dr. Nkatia, he finds out that he has some, underlying chest pain, and that gets worked up, and he has coronary artery disease. So now he can't have the surgery. He has to get a stent placed. He has to be on Plavix for at least 6 months. Correct me if I'm wrong. And so that delays any procedure that can be done on him. He waits for 6 months. He then undergoes surgery. By this time, the cancer has progressed. It's more extensive. The surgery is more challenging. His, because of the fact that he's a smoker, his recovery is also poor because he has poor wound healing. He's more at risk for getting an infection after surgery. He's more at risk for hernias and more at risk for bad outcomes. And so you can't think about smoking in a vacuum. It affects not just cancer, but every single aspect of your tissue. So, again, cancers of many organs, wound healing, risk for infections, heart disease. It probably touches, more organs than any other bad habit that I could think of.
Absolutely. So the biggest one, like you said, smoking by itself can cause plaque buildup in all your arteries, right, from head to toe, and that includes your carotid arteries, your coronary arteries, and the big arteries in your body. Then if you're a big smoker, what can happen is those plaques can become unstable, and the plaque can actually break off and go to distal vessels and cause heart attack or stroke. So smoking is actually a bad thing for your health overall.
Yeah, I just want to throw out there, we're talking a lot about smoking, and I have a note here from Moira, something that I think Dr. Elsreef was going to talk about, but we do have a freedom from smoking program through Garnet. So you can just go on the website and check that out. And it's some smoking cessation classes, which has been shown to help if you are a smoker or a smoker, definitely refer them to that. And talk to your doctor about a medication to help you quit smoking. I mean, there's a bunch of medications out there. Unfortunately, Chantix is not available right now. That had been my favorite one. It worked really well. Hopefully it comes back, but there are a lot of other medications, and good.
I actually like to prescribe things like, the gum, the patch, and like bupropion actually was very effective for people that like to smoke.
Yeah, even if someone can cut back, I think, right, it's the risk reduction is good there, so it's worth it, even if you just cut back. I mean, if you can't quit completely. I was going to throw out a little bit about, right, so just as you guys were talking, I was like, your lifestyle, exercise, diet, avoiding unhealthy habits, basically, like to have heavy alcohol use, tobacco. I mean, these are the things, it's like in the 20th century, I think there was this idea that, kind of when you turn 65, you're probably going to have a heart attack or die of cancer, or in your 70s. And actually what we're learning now in the 21st century is almost all of that is caused by something that the person is exposed to throughout their life, whether it be like the typical American diet, high in saturated fat, low in fiber, alcohol use, tobacco use. A big thing for those of us with, all of us have grandparents that, or my grandparents had industrial exposures. My grandfather was a mason, and he had, so that was something big. People were just exposed to things, asbestos, but as we're sort of learning more about that, we're realizing that these aren't things that have to happen to you. You don't have to get coronary arteries. You don't have to get, it's not a fait accompli. It's not, that you're definitely going to get them. So living a healthy lifestyle is actually, worth it. And it does help reduce risk. And yeah, stress reduction, stress management, is also really important. I mean, we live in a really difficult, demanding world. I mean, even when we're not in a global pandemic, it's, our society is very, very stressful. Cost of living, Orange County is high, and people are, living very, I believe, stressful lives these days. And I think we all have to remember that, be kind to yourself and take care of yourself. So self-care, I'll tell my patients, like, look, treat yourself as if, especially for people who have kids, they kind of ring you. Take care of yourself as if you were taking care of your child. You're going to feed yourself something healthy. You're going to make sure you're getting enough sleep. You're going to make sure you're getting some exercise. You kind of have to take care of yourself like that. So, meditation, mindfulness, those are all good things too. So that's kind of my little lifestyle plug that I try to ask people to remember too. Oh, okay. People can post questions. Yes, please post questions. That would be fun. All right. So where are we at? Time check. 7:30. Okay. So I want to leave around 15 to 20 minutes at the end for questions. We have, so it was about 10, 15 more minutes to talk. So we have a couple other topics. One of them is, when should I worry? What's the time when, I know this is kind of a broad topic, but what are some things that you think about that you should probably make sure you go see a doctor right away? And I guess we'll change it up and go with Dr. Greenblatt first. Maybe just one or two things that you think of.
People need to worry if something is staying on your skin and growing, darkening, or changing. I know I've said that before, but it bears repeating. It's a very simple rule. There are a lot of details people read about detecting skin cancer. If they forget all the details and simply watch for something changing on their skin, it'll be life-saving for themselves or a family member. And I mean that quite literally. A pigmented streak under a nail, a dark spot on one's back, and you notice it on your spouse and you say, honey, that spot is growing or it's darkening, it's catching my eye, I'm not even exactly sure why. If those changes are brought to a dermatologist's attention, lives are saved. I mean, I'm seeing new melanomas in my office every week. The statistics now are that approximately 2.5% of the Caucasian population is going to develop melanoma in their lifetime. That's incredible to me. I mean, that's like 1 in 40 people. So you look around you, there's plenty of melanoma, and it typically will begin with something changing. Spouses are very good at noticing that, particularly wives noticing it for husbands. That's generally the pattern that I see. Husbands are more in denial. If something's not really painful, they tend to just minimize it. But the women notice things that are changing on their husbands. They urge them, they force them to go see a dermatologist, and we catch things and we catch it early. So the absolute key is change. A streak under a nail, a dark spot, a mole that is now itchy or bleeding, something growing that continues to enlarge. Any kind of change like that on the skin should absolutely be brought to a dermatologist's attention. And many times they're not serious. People should not worry about going and be scared of what's going to happen. Very often I look at things, and even though they may have changed, they're okay. They're not necessarily cancer. But at the same time, I see cancer every day. I'm doing biopsies every day. A skin biopsy is a literally a 60-second thing. It's very simple. It probably hurts less than having one's blood drawn. Very easy, get a quick answer, low tech. I think people need to just be concerned about change on their skin.
Great, thank you. Anything from you, Dr. Borby, about kind of worry signs, things that they should definitely go see their doctor for?
Absolutely. So I want to actually touch first on things that maybe people might worry about at this point that they shouldn't necessarily worry about. So for example, I'll have a man come to see me and he'll say, "Doc, I'm getting up 4 times a night to urinate. My stream is weak. You know, do you think this is prostate cancer?" And I want to reassure the audience that usually these symptoms do not indicate prostate cancer. These symptoms are probably more indicative of something called BPH, or benign prostatic hyperplasia. This is a totally separate condition unrelated to prostate cancer. So in BPH, this is a very common condition in which the prostate will enlarge over time. And as it enlarges, it actually will sort of choke off the urethra or the urine tube and cause the symptoms. On the other hand, prostate cancer, for the most part, does not cause symptoms, which is why it's so important to undergo the screening. Another, so what are some other worrisome signs in urology? Something called hematuria, which means blood in the urine. So if somebody is starting all of a sudden to urinate blood, especially if it's a painless type of urination, then it's probably not associated with an infection or a stone, and it is more worrisome. Conversely, again, along the same lines as, well, what's not worrisome? Somebody, and we see this very often, and it's sort of a touchy subject for men to talk about, but blood in the semen is actually very common and much less worrisome than visible blood in the urine. Blood in the semen is almost always due to a benign inflammation, whereas blood in the urine is much more concerning and should be brought to the immediate attention of the urologist.
Thank you. Yeah, great points. Okay, Dr. Ngatia, do you have any word I could probably think of? I'm sure everyone could think of a few.
So there's a lot of stuff. So I think what I'm going to say is that if you have any symptoms, and that includes, I'm going to start from head to toe. So if you're male or even female, and you have headaches every single day, you are dizzy, you are passing out, please see your doctor. And that includes your primary care or your cardiologist. Now, if you have a lot of chest pain, right, usually it's pressure in your chest, it goes to your arm, it goes to your jaw, you have chest pain or shortness of breath when you walk around, when you exercise, it's a time to see your doctor. Now, how about things like when sometimes you go blind completely, or sometimes you have acute, like your left arm just gives up, all right? It's a time to see a doctor. If you go to ER, if you have the symptoms. The other thing to think about, sometimes, you have abdominal pain that nobody can explain, right? You have no blood in your stool, no blood in your urine, but your belly hurt and the pain actually goes to your back. Time to see a doctor. The other thing is, if you have multiple family members, right? So you have a sibling or a brother that had a heart attack in his 30s, then you have to be worried, right? So time to go talk to your doctor, go make sure you get screened for things like aneurysm, like I talked about before, just to make sure there's nothing that can kill you.
Yeah, don't hesitate. So somebody made a point, like people sometimes worry about coming in. I mean, look, just come in. We'll figure it out. We're not going to bite. You see, we're nice people. We'll take care of you. So it's going to be all right. You're better off coming in, and we'll figure out what's going on, even if you're not sure. Other times people are like, I'm kind of embarrassed to even come in for this. I'm not sure. Look, your body. If you just think something's not right, just come in and get it checked out, especially with, just with telehealth these days. I mean, that could be a simple phone visit, video visit, email to your doctor, so lots of different ways to get a hold of us these days. I'm going to just jump to the questions because we're getting some good ones here. a couple folks chatted out a couple questions. Let me go to the chat, and I think I saw Dr. Greenblatt already responding. It's getting ahead of the game here a little bit. Look at that. That's beautiful. All right. Well, we'll talk about that one. Let me jump to the first one. Oh, Caitlin Simpson. That looks familiar. I know a family medicine resident named Caitlin Simpson. I wonder if it's the same person. Anyway, can you talk more about colon cancer screening? I guess I'll take that one real quick. Colon cancer screening is now, you can start it at 45 now. You know, they give a firm recommendation still at 50, but they say recommendation class B for everybody at 45 now. And I usually just tell people there are two kind of types of colon cancer screening that you can get. One is a stool test, which is either every year or every 3 years, depending on which one. And then there's the colonoscopy, which, as long as everything's normal, is every 10. The only caveat to that is that's the advice for people who are at average risk. So if you have a family history of polyps or colon cancer, or if you have like Crohn's disease or something else, you might need different screening, but that's more or less the deal with colon cancer. Thank you, Dr. Simpson. I mean, random person also named Caitlin Simpson. And there's another familiar name, Richard. Hey, Richard. Yes. Okay. So here we go. We'll let Dr. Greenblatt jump in. Unusual dry peeling skin. Is that something that would be corrected with lotion, oily face, those kinds of things? Yeah. And I don't know if you want to just comment on your response there, Dr. Greenblatt. You see that question again.
You might be on mute, Dr. Greenblatt. Your mic might be on mute.
It is no longer. There you go. Sometimes very flaky skin is just dry skin, and moisturizing lotions and gentle cleansers will be very helpful for that, especially in the winter when the humidity in your home drops when heat comes on. But sometimes dry skin is a sign of another skin disorder that needs stronger medications than just moisturizers. For example, psoriasis has very dry skin. Sometimes eczema has very dry skin. Ichthyosis is a condition sometimes inherited with unusually dry skin. So dry skin is worth trying to treat with moisturizers and gentle cleansers. And if that's not doing enough, it's worth getting an opinion from a dermatologist as to whether it needs more. As far as oily skin, there are things that will take the oil away. There aren't many things that actually reduce the oil production other than by treating hormonally, which isn't a healthy approach or an approach I recommend unless the hormonal levels are abnormal. And that's something we test for in some people, for example, with very persistent acne who have excessively oily skin. And if they have abnormal hormone levels, correcting that will correct the excessive oiliness. So sometimes dryness is just dryness, and sometimes oiliness is just oiliness, and sometimes it's more. So if you're not getting the progress you'd like, it's worth showing that to a dermatologist.
Great, thank you.
Sure.
All right, and I'm gonna go, there was another question about, can smoking cause urinary retention? Good question. Dr. Nkati, I'll let you weigh in. No, I'm just kidding. Go ahead,
no,
Dr.
yeah.
No, go ahead. That's you, Sam. Go ahead.
So I'm trying to think of an example of how smoking can cause urinary retention. That might be the one thing that it does not cause, but I'll tell you, it can certainly have the opposite effect. It will certainly cause you to urinate more frequently because the byproducts of cigarette smoking end up in your blood. They get filtered by the kidney and end up in your bladder, and they will irritate your bladder and cause you to urinate more. So actually and when somebody is telling me that they're urinating frequently, when I find out they're a smoker, that's the first thing I counsel them to do is stop smoking. You know, there is a rare condition called urethral stricture, which is actually a scar tissue that develops in the urethra, unrelated to the prostate, but further along in the urethra. And there's probably a higher incidence of strictures in folks that smoke. And the scar can actually get so narrow that you can be unable to urinate through it. But that's rare. So to answer your question, I mean, typically, no, it can in some rare cases cause urinary retention, meaning unable to urinate, but it usually has the opposite effect on the urination.
Yeah, that's what I was thinking about too, because I think it was Dr. Galarno. He's another one of our urologists. I was talking to him, and he's like, really before I'll start anybody on any medications for BPH, I'll review their diet and things like that, and see what they might be doing that's causing bladder irritation. So can you just talk real quick about some other things that might cause that for men who are having urinary symptoms? Because I bet you that's probably a common issue in our audience.
Certainly. So the typical risk factors for bladder irritation, or what we call an overactive bladder, or urinating frequently. Well, one of them you can't really control, and it's prostate enlargement. There's nothing really at this point that we know that you can do yourself that's going to stop your prostate from growing, if that's the way your body has been designed. But what are things that are in your control? Well, certainly coffee. Coffee, not only is it's not only a load of liquid that has to be excreted, okay, in the urine, but the caffeine is a diuretic, so it's actually going to stimulate your kidneys to produce more urine. So you're going to have to go more frequently. We mentioned cigarettes, spicy food. But I've had a number of patients who come to me who don't have any of those bad habits, but what they do have is significant obesity. And I tell them, just think about it logically and physically. Your bladder is all the way down at the bottom of your body. So all that weight in your trunk, all the fat and liver that's become fatty, and all those organs are actually sitting on your bladder, putting pressure on it all the time. So rather than put you on a medication to calm your bladder down and maybe make it squeeze less and have you urinate less, if you lose weight, I see, and I've seen it, people will have a great improvement in their urinary stream and their frequency of urination.
Yeah, that's really good advice. Thank you. All right, Matt, we've got another question from Matt. What affects balding and how do you prevent it? That's a good question. So talking about male pattern. Oh, actually, you know what, Dr. Greenblatt, let's let you jump in on that one. That's in your wheelhouse, maybe, right? Balding?
Sure.
Yeah, okay.
A lot of balding, I think, is out of control and it's pre-programmed, and it's not real. There are some myths, it doesn't come from your father's side or your mother's side, and male hormones drive hair miniaturization and hair loss, and that's in both men and women, because men and women both have male hormones. So it's a normal byproduct of the effect of hormones on the hair follicles. And so we actually use a drug that was primarily used by the urologists, finasteride. It interferes with the effect of the, let's say, the testosterone on the follicles of the hair of the scalp. And for that reason, it helps preserve hair and actually helps grow some hair in people. But there are some other things that are within our control. For example, if there's trauma to the scalp, if there's an injury, or particularly a thermal injury, a burn of the scalp, that can cause scarring and destruction of hair follicles. So you get hair loss and it's permanent. There are some chemical injuries to the scalp that people undergo. So thermal, chemical, there are some nutritional deficiencies that promote hair loss, and that's where the varied diet and plenty of fruit and vegetables comes in. That would be very uncommon unless somebody's really restricting their diet. There are some medications that contribute to hair loss, and people read the package inserts or look them up. Some of the anticoagulants, some of the beta blockers, these are high on the list of having the potential to contribute to hair loss. There are some skin diseases and skin disorders that can cause hair loss. And again, I think of psoriasis, for example. So there are some correctable factors, both medication, environmental, other diseases, thyroid, internal disorders, etc. And then there are the genetic components that aren't reversible, but If people are avoiding injury to the scalp and taking care of their other medical conditions and watching for any potential side effects from medications, they're pretty much doing what they can do. And if they are noticing hair loss early on, that's worth talking to a dermatologist, because there's some skin disorders that are reversible, that are treatable, that can help preserve hair and help avoid scarring of the scalp, which is what permanently destroys hair. So if it's caught early, like most things in medicine, we can intervene, we can prevent that hair loss.
Yeah, great. I mean, again, just hearing that's a whole other probably
Yeah.
hour talk there about the different causes of balding. Okay, let me see if there are any more questions. If not, give folks a chance to type in any additional questions they may have. If not, we'll kind of wrap up with some closing thoughts. Give just a couple seconds there. All right. Seeing none, I will proceed to the
I think
final
talking about
thoughts.
medications too, so
Go ahead.
Greenberg talked about the fact that things like beta blocker can cause you to lose your hair. So the key here is that if you're on something for your heart, say beta blocker or something that can give you baldness, make sure you talk to a cardiologist, a dermatologist, your primary care, just to make sure you don't stop it, without telling them, right? So
Absolutely.
sometimes that can lead to heart attacks and other stuff.
I always tell patients, you're on a medication that possibly could be impacting your hair. You certainly don't stop it on your own, and you certainly discuss it with your physician who prescribed it to see if there's an alternative. And if not, you have to keep that medicine, and we have to work around it.
Yeah, I didn't know that about beta blockers. That's an interesting one.
Blood thinners in particular. I see people with injuries from curling irons, thermal injuries causing scarring. And you see
Right.
people with systemic disorders like lupus, which can cause a scarring alopecia, and some other medical conditions, and thyroid impact, and lichen planus. There are a bunch.
Wow.
Yeah.
I was about to say, see, this is the kind of thing doctors say. Wow, that's pretty cool. It's like, no, it's not. It's bad. It's not.
Right.
This is what
Cool.
this is what. Yeah, interesting. We these are things we like to know about so that I can share that with another patient down the road when you're learning something. Okay, so I'll just one more quick check at the chat. Got one. Oh, look at this. Okay, this is a consult here for Dr. Incatia. It might be let me try to put this in some general terms.
That's a great question.
It's a good, I mean, do you want to take a stab at that? It's
Yeah,
awful
sure.
specific.
It's actually an excellent question.
Go ahead.
Yeah, so the question here, the patient has bypass surgery 5 years ago at 30. He was very young, right? So it's a guy, a patient that may have family history of CAD or blockage in the heart, right? That's a big one. EF is just the heart function, the pump function of your heart. Then he lost some weight through VSG. And the question here is, how long does he stay on something called statin, which example is Lipitor or Crestor, and the blood thinner, that include aspirin or maybe something called clopidogrel. Now he says his A1C, which tests for how bad your diabetes is, was 14, now it's 5.8. So in this case, when you have blockage in your heart and bypass surgery, the idea is that you want to prevent future heart attacks, right? So for someone like you with bypass surgery, you're stuck on this aspirin and Plavix and Crest and statins for life. So that's the key, because if you were to stop it, you may develop more blockage in your heart and eventual heart attack. So I think the key here is that lifelong aspirin, lifelong statin, which include Lipitor, simvastatin, Crestor, and other stuff. Now, so by the way, good job with your A1C. I think that's amazing. 14 to 5 points is amazing, right? So that actually reduces the risk of future heart attacks.
Yeah, I think it's like your situation, your health situation is obviously worlds different than the you that had that cabbage several years ago, but you still do need to continue on the medications, because even you've got a risk for having another heart attack, and it's just the risks and benefits of staying on the medicine definitely would have you stay on it. So Oh, good answer, Dr. Ngatia. Okay,
Right.
good. All right.
But I would
Um,
say that sometimes, people have, things like nosebleed, they have blood in your stool, blood in your urine. If it's a minor bleed, we say, please stay on it. If it's a major bleed, right? So you bled to a point where you were dizzy and your blood count is very, very low, we can probably take you off a little bit and at some point put you back on it when that bleeding source is found.
And if I could just jump in and tag on to that point, I see a lot of patients that are on anticoagulation. People are living longer. They develop cardiac diseases. They get put on anticoagulation, or antiplatelets, such as Plavix or Coumadin. If somebody comes to see me and they're on Plavix and or Coumadin and they're having blood in the urine, I do not say, oh, that's just simply a byproduct of anticoagulation. You cannot make that assumption. I can't tell you how many times, well, for example, this person was a smoker. That's why he got a heart attack. But also he developed bladder cancer. And it's not just because he's on Plavix for his stent that he has blood in the urine. It's because he actually also has bladder cancer. So don't just jump to the conclusion that the blood in the urine or the blood in the stool is just because you're on a blood thinner. See your doctor, see your urologist, see your gastroenterologist if you have any of those symptoms.
The other thing here is our patient here is on atorvastatin, which is one of the stronger statins, right? So the main side effect may include muscle pain, muscle weakness. If that happens to you, there are a lot of options for you, right? So talk to your doctor, make sure they know about it, and we can give you something else.
Yeah. All right. There was one other good question that came up, and with everything that's going on right now, stress, mental health is huge. I mean, I can speak as a healthcare provider, we're dealing with a lot of stress in our ranks. So we see it every day. I would just go back to the basics, and this sounds simple. I mean, if you're getting to the point where you have serious mental health, like, depression, those things, definitely see a doctor, get on a medication. If you're having any thoughts of suicide, call the suicide hotline. But if you're just kind of feeling kind of down, I would just say try to get back to basics, self-care, eating healthy, exercising, getting enough sleep. Find something that gives your life meaning, a hobby, spirituality, faith practice, community. These are things which we don't really talk much about, but as human beings, we have to have those larger activities that give our lives meaning. So, just got to do all of that. I tell patients, like, stress management is like a stool or like a chair. You have to have all these different, legs to that chair or that stool that you're kind of sitting on. And especially in tough times, you have to lean on that. So reach out to family, reach out to friends, reach out to your faith community, whatever it is, and pull all the levers, to use another analogy, to get yourself well. And if you don't, see a doctor. There's also a lot of stuff online. You can go online and get counseling now. BetterHelp.org is one website. I don't know if we're allowed to give websites, but that's the one that I always give people. You can go on and get a therapist, and start talking to somebody. So we're about out of time, but thanks for everybody for participating. Thanks for the great questions. And to our wonderful panelists, speaking as a self-identified man, men's health is very important to me, and I'm sure to all of us on this call. And take care of yourselves, guys, and get the screenings and be healthy. I think we have a slide about how to make appointments with each of the doctors that were featured. Moira's going to show that right now. Okay. And looks like, yeah, so there you go. All right, everybody. Well, have a good night, and like I said, take care, and thanks for participating.
Thank you.
Thank you, Joe. Thank you, everybody.
Okay.
Take care.
Thank you, guys. Thank you.
Pleasure.